Today at the National Press Club, epidemiologists and immunisation experts Robert Boye, Mary-Louise McLaws and Senanayake. As Australia prepares to roll out the coronavirus vaccine, they'll be answering questions about the approval and development process from the National Press Club in Canberra.
Yuma, hello and welcome to the National Press Club of Australia for today's Westpac address. I'm Misha Schubert, a Vice President of the club, and I also happen to be the CEO of Science and Technology Australia. We're broadcasting today live from the nation's capital, and so we honour the Ngunnawal and Ngambri people who have lived this country and loved this country through the vastness of time. Today we bring you a very special event. In coming weeks, Australia will commence the largest national vaccine rollout in our history. So today we wanted to bring you a special forum to give the public, you at home, as well as our working journalists in the media, the chance to ask questions about the rollout, vaccine development and the continuing evolution of Australia's COVID response. Three eminent experts on vaccines, epidemiology and public health have agreed to share their expertise with us all today. And when we did a similar forum at the outset of the pandemic last year, it turned out to be our most watched broadcast of 2020. Robert Boye is an honorary professor of paediatrics and child health at the University of Sydney, and he's also the former head of clinical research at the National Centre for Immunisation Research and Surveillance at Westmead Hospital. Mary-Louise McLaws is Professor of Epidemiology, Hospital Infection and Infectious Disease Control at UNSW Sydney and a member of the World Health Organisation's network of global experts on COVID-19. And Senanayake is the infectious disease physician in Canberra and an associate professor of medicine at the Australian National University's Medical School. If you're watching or listening across the country today, we would love you to join the online conversation. Just tag our handle at PressClubAust, AUST, and use the hashtag NPC. So let's get underway. Would you please join me in welcoming our first speaker, Professor Robert Boye.
Well, it's a privilege and a real challenge for me to be speaking here today. I've not done that before. SARS-CoV-2, the virus, causes COVID-19 disease, and it's turned the world upside down. My expertise is in infectious disease prevention. My training is in vaccinology, epidemiology, and clinical medicine. I helped to form what's called the Oxford Vaccine Group more than 25 years ago when I started my research career in Oxford. Today I wish to briefly reflect on the many vaccines that have come into being in less than a year and which we're about to use and we are using around the world. I hope to illuminate or at least to inform discussion about the vaccine rollout. More than half a dozen vaccines have already reported very high levels of protection, especially against severe disease, hospitalisation, death. 90 to 100% protection. Wow. But it's very hard to compare the different vaccine studies because they're not comparable because they have differences in their study designs, who they include, what endpoint they use, and so on. Generally, they include healthy people with fewer medical problems. They don't have diabetes or lung disease often. Some studies are better at including people with lots of risk factors in people for disease. So the real-world protection that we expect will be less, and 90 to 100% against severe disease may hold up in best settings, but it may be less in other places. I'd like to talk about, though, a potential additional benefit that people have not discussed to this point about the AstraZeneca vaccine, especially in the South African population, where it does appear to be less effective, and you would have heard reports in the last 2 days. Well, in counterbalance, we know that the virus has mutated and it appears to be less well protected against by vaccine. We've had reports in the last week of Johnson & Johnson, of Novavax, having 90% protection, but then in South Africa only 60% or so. I'd like to contend that the effect in South Africa may not just be the virus, but it might also be the population, the people. Because they live in such a crowded situation in many cases, apart from a few rich people, they have a much higher force of infection, so the virus can spread more easily from person to person. So a virus vaccine like Johnson & Johnson or AstraZeneca that appears less effective may be partly to do with the population and the behaviour. So a 60% effectiveness in South Africa might actually be 80% in a richer country with less crowding and a better health system. Now, the South African variant is worrying us. I'm not trying to downplay it, I'm just trying to put it in perspective. It has arisen through natural mutations. In flu, we call that genetic drift. And it's not a result of vaccine. It's not because of vaccine-induced antibody. New viral variants are emerging all the time, and a new one comes to dominate about every 3 months. So the one that dominated a year ago has long since gone, and we're dealing with other variants. We are going to get a new variant. It just doesn't have a name yet. It might be called Canberra, but I hope not. Importantly and interestingly, these new variants, and now I'm going to be positive again, are likely to mutate and tend to cause milder disease over time. Indeed, all the clever virologists I know are saying within 2 to 3 years, it may be more like a cold than the severe pneumonia that's currently occurring. So that's pretty encouraging. It's a speculation. It's based on previous coronaviruses doing that. It's based on flu virus doing that. We had a pandemic 11 years ago of flu. It now mainly causes milder disease. So another current concern is protection of the elderly. We've got a vaccine that is being developed, it's being manufactured, it's about to be rolled out, 50 million doses in Australia. That's the AstraZeneca product, a viral vector product. That vaccine has not been adequately tested in the elderly. But what does that mean? What does that mean? It means that there's a lack of information, not that the vaccine isn't working. And we need more studies, and they started them last year, and they did it in elderly people in the US. And given that they report every few weeks and provide new publications, and I read them for hours on end to understand them, we're going to have another report within weeks, probably about the elderly in US population. So the TGA will be informed of that, and they'll then make analyses, and in real time they'll make decisions, and we'll hear about it very quickly. Did you know that over 20 agencies already in the world have approved the AstraZeneca vaccine, and generally included older people? We know that the EU, in terms of its overarching regulatory body, the EMA, the European Medicines Agency, has approved the vaccine across the ages 16 up to elderly. However, about a dozen EU individual countries have said, we're not going to use this in people over 65. So the TGA has a real challenge to make sense of the data and make a good decision. What may not be well known is that over 20 agencies around the world have already approved the Russian vaccine. It's also a viral vector vaccine. It's very interesting. They deal with the first dose with one virus as the vector, and the second dose with a different virus. Both adenoviruses, both cause very mild colds. And because they're not replicating, they don't cause disease at all. But that's been passed by regulators in 20 countries. So it's not some spoof from the Russians. It's real data with a vaccine that appears to be working well. So researchers around the world have learned extremely fast. Just a brief comment about the mRNA vaccine, Pfizer, Moderna, and others. It is quite extraordinary. We've never had a vaccine like that registered before, but we've been working on it for 10 years. So it's not as if it's a new platform. We've just got better at it because we've thrown money and people. So this mRNA vaccine, in 2 large studies, has reported 95% protection. Great, especially against severe disease. So that's really encouraging. What's even more amazing about it is that they can revise it, change it, update it within 2 months and manufacture a new product within weeks after that. I mean, that's just extraordinary. That's never been possible before. So the other methods are a bit slower, like the method we're using with the viral vector with CSL Seqirus and Oxford University. What they've learned is a few simple things, which I won't go on too much about. A two-dose approach does seem to be more protective, especially if you widen the interval between, so that if you have 2 to 3 months, the immune system is trained much better to respond more strongly the second time. And there's also growing evidence that you can prove the vaccine is likely to be effective if you simply take a blood sample from someone who's vaccinated, go to the lab and mix it with virus, get neutralisation, and that is a proxy for protection. So in the future, we may be licensing vaccines on much simpler data, requiring only hundreds of people, not tens of thousands as we currently do. So because of these blood tests, we do have some confidence that the AstraZeneca vaccine will work in the elderly in Australia. And we remember too that all the other vaccines that have included the elderly have shown protection in the elderly, and they have similar blood type tests as well. So we've got reasons for confidence, but we don't have as much data as we want. Mild disease may be less well protected against by vaccine, but that's always been the case with vaccines. They tend to prevent severe disease and hospitalisation better. But milder disease, there may be some protective effect, and then that may translate to preventing transmission and give better herd immunity. But that's the topic for other people to discuss, and I'd happy to cover that in questions, but there isn't time to talk about it now, and other people will deal with it. I could talk for hours, but I'm on my last page. My teleprompter is telling me. So to conclude, we have 3 very good vaccines in Australia, and we're going to roll out very soon. The TGA has a very important task, and we can't second guess them because they have information we don't have, and they get it before we get it. And they have the expertise to evaluate it very well. We know from a bunch of trials that vaccines are effective and safe for about 3 months. Not that they stop being effective and safe, we just haven't had follow-up for more than 3 months. And so as part of TGA approval, it will be vital, and it is intended, that every vaccine is followed for at least 2 years for safety and effectiveness. And that will be part of their conditional licensure. At some point quite soon, we won't be able to do randomised controlled trials. And the reason is obvious, not just that they're extremely expensive. We can't deny people in the control group vaccine when it works. So we can't be going on giving placebos on and on against a disease that can kill you. So we may well benefit looking forward from what's called a heterologous approach. That's where you use one vaccine for the first dose to get the immune system going and provide protection for at least a couple of months, and then a second, slightly different vaccine the second time. And that might give a broader, better protective immune response. So that might be one way of dealing with concerns about one vaccine versus another. Use 2 and get an even better response, perhaps. Vaccination is not a panacea, despite the fact that I've devoted my career to the study of vaccines. They're part of the big picture. So they're a fantastic addition to all the other measures we're currently doing. We won't be able to stop washing hands and social distancing. That will remain important for months, if not a few more years. But vaccines will make a big difference. Thank you for your attention.
Professor Mary-Louise McLaws.
Thank you, Robert, for setting the scene. So I've had the fortune or misfortune of having experience with SARS in 2003. So from an epidemiology perspective, I'm very precautionary. So you will hear a precautionary approach to handling this outbreak, but particularly how we're going to ensure that some of these variants of concerns, these strains, are going to impact on the rollout of this very important vaccine program. Now we've seen today, sadly, we have reached an envious case number of 107 million cases in the world and 2.3 million deaths. And the trend in deaths is not going down yet. The second key take-home or trend at the moment is a 7-day pattern that European and the Americas continue sadly to contribute the majority of cases to our global case numbers. 82% of all cases, 81% of all deaths. Therefore, we are at constant risk in our quarantine program. In terms of case numbers, it would have been reasonable to expect that high GDP countries would have the knowledge, the strategy, and the resources to use low-tech public health, hand hygiene, masking, keeping distance, and augmenting with testing. And what you would have seen was a very low number of infections in high GDP countries. And I've graphed this and found that sadly, the only ones that have managed that include Norway, Singapore, Australia, Hong Kong, Finland, New Zealand, and Japan per million population. So we are in an envious position, but so should the rest of those high GDP countries. So what we have is the should have and the could have countries. And the countries that are quite frankly shameless in their lack of controlling the pandemic with very low tech resources sadly include the US, UK, France, the Netherlands, Sweden, Israel, Switzerland. And they could have done better. There, of course, are the countries with a medium GDP that should have been able to do better. And then, of course, the countries with the low GDP have done better per million. But now, instead of being in a position where we in high GDP countries could protect the rest of the world from our excellent interventions, we are now seeing national vaccination approach, where we're rushing to be vaccinated, and certainly the US, the UK, and South Africa really need this vaccine, instead of we in the high GDP being able to continue with this low-tech approach so that the rest of the world, we have 7.7 billion people. The rest of the world could have been vaccinated first, making everybody safe. As Dr. Tedros at WHO says, none of us are safe until all of us are safe. So now I'll just remind you of what Robert has reminded you about the variants of concern, the strains. So we have variants of concern that are at risk of seeding our community. And it therefore makes it very important that we have no breaches at all in our quarantine program, none. We have the B117 from the UK that took just 4 months to become the circulating virus at something like 83% of all circulating strains. The South African virus took just 3 months. And yesterday, of course, we've heard that sadly in the average age of about 31, in 2,000 people, it looks as if their vaccine won't protect them at any more than about 40%. And then there's the Brazilian strains, and that became the variant that was circulated and the predominant variant in 1 month. And therefore, I constantly remind you that we do need to shore up our quarantine program. It can't be great, it has to be the very best, and we have to have a national approach with very best practice. So about a month ago, I published a calculation, a simple calculation, that with this very challenging rollout for Australia, we needed to vaccinate 170,000 Australians per day for 240 days. That's an enormous undertaking, and it's an undertaking that we need to help the authorities by keeping our distance, hand hygiene, wearing masks when we're asked, but also by the quarantine program being the very best it can be. And sadly, we have heard today that there are 5 cases that have leaked into the community potentially by staff, and the staff are very important, and I'm very pleased to hear that they're getting the Pfizer vaccine. So, but we can take a great deal of learning from the 3 countries that have rolled out or started to roll out their national program: Israel, the UK, and the USA. And they've been doing this for 7 to 9 weeks. And what we can learn from this is that it does take many weeks to reach the peak at the rollout. And the peak for Israel, yes, it's 9 million people, reached 172,000 injections per day. And remember, I'd calculated we needed about 170 to get about an 80% coverage. Of course, when your population gets bigger, the UK has only been able to get just over 400,000 per day. And of course, the US have lifted their game and have got to 1.7 million injections per day. It's an enormous undertaking, and it can be done. But I would stress to everybody in Australia that when it's your turn to get vaccinated, get vaccinated. And I'm going to just take you through some sobering reminder that this vaccine is not the silver bullet, the magic bullet, but it's the only bullet that we have to help us with the low-tech interventions. So having a look at what we would need to get herd immunity, the Pfizer and AstraZeneca that is in our portfolio at the moment have not been able to provide evidence, and they will eventually, about whether or not they have what's called transmission blocking capacity. In other words, protecting us from not just getting severe infection, getting any infection and transmitting it. But as Robert has mentioned, there's a great possibility that this will happen, and we will hear more about this. But nevertheless, I redid some calculations, and of course, with the Pfizer, it has a 95% protection, and we can roll that out to fewer in our population to get herd immunity in the absence of any variants of concern at about 70% of the population. But once you add just even the UK variant, not the South African variant, the UK, we'd have to roll it out to about 85% of the population. So if we look at the AstraZeneca, and I've taken best case scenario, I've taken that, of course, it will protect us in the 80% range, 82%. We would still need, with AstraZeneca and the Pfizer, at the 40-60 ratio, to have at least 75% of the population covered. If you add, of course, the variant, that increases, of course, to about 80%. And even further. And of course, if you have a look at when AstraZeneca hasn't done well in either the UK, when it gets to about 70% protection, and of course in Brazil with less protection in the 50, you have to roll it out to even more people. So if we need any more lessons, and we need to lessen up quickly and learn, we need to roll this out to everybody. And I would commend everybody to take whatever vaccine they are offered, because we need as many Australians as possible. Now, these vaccines aren't perfect. We will need about 160,000 to about 190,000 injections per day. And that's going to take a lot of challenge by our authorities, and we need to help them reach that amount. They are coming up with great ideas to use pharmacy, GPs, etc., and that will be much easier with the AstraZeneca vaccine. So I did some calculations on what will happen if you have the vaccine, particularly the AstraZeneca, and you may not be protected. And with the 40-60 ratio, we could have between 13 and 25% of our population, including our guests, because we need to cover them as well, that will not be protected. And we really need to think very seriously about what to do about that. But Robert has mentioned the idea of what's called mix and match. And in fact, if we can learn from the South African experience, and they may well, because they've placed their rollout on pause, they may well choose to do a mix and match with the second dose. So use Johnson & Johnson or Moderna or one other. And this may be an opportunity for us to think about doing the same thing, because we need to protect everybody. Because if we got up to 25% that are not going to be covered, then we could still have a circulation going round and round. Just to remind you that we come from all different countries. Our families come from around the world, and we will be opening up our borders probably next year. I can't see them opened up before then. And we will be travelling and receiving our family members. To ensure that we are safe, please get vaccinated. So just to reiterate, to have the very, very best chance of putting an end to this virus and to getting back to some semblance of normality, we need to remember that there's constantly an enemy. And instead of going at the enemy as separate states and territories, we need to go at this enemy as a nation and have the very best of each one of the states' experiences with the quarantine program. Learn from that so that we don't get any leaks. Thank you very much.
We now welcome to the podium Associate Professor Sanjaya Senanayake.
Ladies and gentlemen of the press, honoured guests, my esteemed colleagues, I've been asked to talk about COVID and the future, which is no mean feat. Unfortunately, I do not have my crystal ball or tea leaves with me today, but I shall endeavour to do my best. But let's start with the present and look at the global vaccine rollout. At this stage, over 140 million people have received a dose of vaccine. Now, the US is leading the way in terms of the number of people who've received a dose of vaccine and the number of people who've received a dose of vaccine daily. But probably a better indicator of the success of the program is the percentage of people in your population who've been vaccinated. And so far, Israel and the United Arab Emirates leads the way. Now, those three countries that I've mentioned should be well on the way to achieving 75% coverage of their populations within the year. So does this mean we'll be able to eradicate COVID, get rid of it from the world? Well, let me tell you, we've only ever eradicated one infectious disease. That was smallpox, and that took a lot of hard work. Interestingly, the coronavirus precursor of COVID, SARS, has disappeared from the face of the planet, but that is a great mystery. At the other end of the spectrum, we have 4 circulating coronaviruses that cause the common cold that have been around for decades. And I suspect that COVID is going to mirror the trajectory of those particular organisms, becoming a persistent presence in our society, leading to intermittent incursions, causing some hospitalizations and deaths every year, but largely leaving untouched our vaccinated population. However, I see 4 obstacles getting in the way of us achieving that relatively harmonious symbiosis that I've just discussed. 2 of them we're already very well aware of, which is we don't know the duration of immunity of these vaccines. And it may well be we're mixing and matching and giving an annual boost with the latest version. Also, we don't know by how much these vaccines reduce transmission of infection. The other 2 points, however, are intertwined. That is, the global vaccine rollout and the emergence of new strains. Now, at the start of my talk, I said some positive things about the global vaccine rollout. However, there is a flip side. Only about 70 nations have started to vaccinate their populations. And at the current rate of vaccination, it is estimated we won't reach global coverage of 75% with vaccines for about 6 years. Not 1 or 2 years, but 6 years. In addition, Oxfam has said that by the end of this year, there will be 70 poorer nations where only 1 in 10 people have been vaccinated. So there is some inequity there. So we move on to these strains which have emerged, and their emergence, I must admit, has been somewhat surprising at this stage of the pandemic. The most likely reason for this is the sheer volume of infections we've seen in the last 12 months, where literally there have been hundreds of millions of opportunities for the virus to replicate and mutate into something more sinister. And if we continue this global vaccine rollout, while in other parts of the world infection continues unchecked, then we will see more sinister strains emerge which might have further impacts on vaccine efficacy. Therefore, if you are a believer in vaccine nationalism, wanting the best impact of vaccination in your own country, you also have to embrace vaccine altruism and ensure that vaccines are delivered in sufficient number and in a timely manner to the developing world. So this paradoxical pairing is necessary if we want to have some sort of harmonious coexistence with COVID. Now, I must say that the efforts of our vaccine researchers here in Australia and around the world have simply been magnificent to get us where we are today. However, when the first person in the US got their dose of vaccine on the 14th of December, 1.6 million people had already died from COVID. In other words, we needed that vaccine earlier. We needed that vaccine before the pandemic. Now that sounds like an absurd or ridiculous notion, but that is exactly what organisations like the Coalition for Epidemic Preparedness Innovations are working on. You might say, why? It's been 100 years between the Spanish flu and COVID. Well, let me tell you, in the last 50 years or so, we've seen over 40 new infections appear. Our global population is growing. We are impinging more and more on natural habitats and interacting with wild animals. And our interconnectedness globally has never been as great as it is now. Therefore, the next pandemic is not 100 years away. It is just around the corner. And what we have learnt from COVID is that a pandemic is not a niche area of healthcare. No, not at all. A pandemic with this microscopic leviathan that is SARS-CoV-2 has invaded every continent on the planet and pervaded every aspect of our lives. So I think here is an opportunity before we forget COVID, and it is true at some stage we will forget COVID, to galvanise into action the greatest minds, the greatest thinkers on the planet, not just the medical minds, but the Elon Musks and others like him, and get them to stop thinking about driverless cars and sending adventurous billionaires to space, and maybe focus on predicting and preventing the next pandemic, but if it occurs, ensuring that we have the correct medications and the correct vaccines available. And I should add, I have no issue with sending adventurous billionaires to space. It's bringing them back to Earth afterwards that's the problem. Anyway, I shall conclude by saying that we are in the midst of what is perhaps the most audacious global public health undertaking in history. There could be many complications and it could go wrong, but I really, really believe that we can get it right. Thank you.